Welcome to another episode of Judgment Date. We've been doing these programs specifically because of the lockdown, trying to give people information about not just the lockdown, but the consequences thereof of the pandemic, both economic, political, and if you wish, medical. And it's perhaps the most central of all of these issues is one we're going to talk about today, which is the whole issue of the regulation of COVID-19. And gives me unbelievable pleasure to welcome Professor Glenda Gray, who's the President and CEO of the Medical Research Council, apart from the fact that she's one of our most distinguished scientists, world-renowned scientists. So thank you very much for being here. And I wonder whether I could start off by asking you the following. And forgive me, I know that that we have reached a point in the world, in South Africa, where everybody's a virologist and epidemiologist. I don't realize you know that you've got so much competition. But I suppose for ordinary people like myself, the first question I wanted to ask was, we seem to be doing everything the different way to the rest of the world, meaning as the pandemic started to rise, people locked down, and then when the peak was reached, they started to relax. Now, we've not done that. Now, is that, so for an ordinary person, that seems so counterintuitive, but maybe I'm wrong.
So we behave like other low and middle income countries. And we went into lockdown relatively early, and maybe one could argue that the lockdown, was long and early, and we did that to try and prevent community transmission of COVID. But when you're in lockdown and you are in a low middle income country setting, you don't have the fiscal resilience to manage the lockdown, and you have to start opening up. And so if you have a look at other low middle income country settings, we're doing exactly what India is doing. They've opened up their lockdown. They had one of the most stringent lockdowns, and they've had to open up their economy. And likewise, many countries in Latin America. And so we're in a situation where we don't have the resilience, the financial resilience to continue to keep our country in lockdown. And we open up as the surge is happening. And we open up as the surge is happening because we've had time, hopefully enough time, to get our medical systems in ready for the surge, and to also navigate the economy. The coronavirus epidemic is going to be around until at least mid next year, if we're lucky. And so we have to navigate the virus together with the economy. And so you have to make certain decisions to try and prevent the onward transmission of COVID, but at the same time try and resuscitate or kickstart your economy. And so we're behaving like most poor countries, and that we can't manage the lockdown forever.
But is this then a trade-off that we have to make, that wealthier countries are more fortunate? Trade-off between life and the economy?
Yeah. Well, I think every country has been devastated. Maybe the country that has not been financially devastated is Germany. But if you have a look at all other countries, the United States of America, China, the UK, even highly resourced countries have had devastating effects on their economy and high rates of unemployment. And so if countries like the US and the UK France suffer from the lockdown and the impact it has on jobs, how much more so would countries like Brazil, South Africa, and India have? And so we have to try and balance lives with livelihoods, and try and find an equipoise where we open up the economy in a cautious way. We know what we have to do. We know that social distancing, wearing masks, washing your hands is the tool to prevent the onward propagation of the virus.
But Glenda, one of the things I've noticed just by my own observation is, as we've really relaxed the lockdown, people are taking this very casually now. All of a sudden, people think it's all over. You walk around, people aren't wearing masks, people aren't socially distancing. When there was the lockdown, there was a sense of imposed discipline. Now there's nothing.
Well, we have to continue to explain to the community, to our citizens, why it's important, why the lockdown happened, and why we have to have ongoing protection. We have to, as citizens, have a social compact with our government, where we say, you know, we'll do our bit if you do your bit, and we have to enforce the respect for life, and that respect for life is maintaining your social distance, washing your hands, and wearing masks, and protecting the vulnerable people in our communities.
So could I ask you then, now that we're down to level, well, I suppose 2.5, I don't know how I would classify that, be that as it may, aren't you expecting now, will we not get an even greater exponential growth in the disease?
Well, we've already seen the surge, you know, so the moment we ease down the lockdown, but that's to be expected. So during the lockdown, community transmission was still occurring. And so what was happening is that the infections were occurring in the household. And it's a matter of time before that spills over into your community and then into society. So it was inevitable that the infection rate would spread because you can't contain transmission in a household. And so the surge is happening, and our surge is happening just very much like what's happening in Colombia, Mexico, India, and Brazil. Is that we have not been able to maintain the lockdown in order to eradicate. It's virtually impossible to eradicate the epidemic, as you've seen even in Singapore, China, now in Beijing. You need extraordinary capacity to be able to really contain the epidemic.
But then can I just ask you, on the sort of modeling that you people are doing, are we now predicting a major surge up to a peak in the next month, 2, 3? And will it be different in provinces? Do you expect the Western Cape to peak earlier, given that we've got so much more down here than we've in other parts of the country?
Well, I think that the Western Cape is the first province to surge, and there may be reasons for that. It may be climatic, or it could be due to the fact that the epidemic was very well established here when we went into lockdown. And so it's probably a combination of both. A whole lot of factors that made the Western Cape go first. And it's hard to know when we will peak. We only know when we peak when we stop peaking. And so we don't know how much we expect. So depending on the models, remember the models depend on the amount of testing you're doing, and we really are under testing in our country. And we've got a kind of a tip of the iceberg kind of feel. So if you have a look at some of the figures that I'm seeing, that according to the models, that by mid-July we should the infections could be around 223,000 to as high as almost 500,000, with a median around 430,000. So that's in 1 month's time, given the doubling rate. So 500,000 infections maybe in 6 to 8 weeks. And we'll have to see how true those are, because those are just models. We're predicting around 40,000 deaths to occur by September, October, and that's and remember that if you have a look at the US, a few weeks ago they were having 1,000 deaths a day. They're now down to about 900 deaths a day, and so it's very hard to turn off this epidemic, and we need biomedical interventions to help us. So we're in here for the long haul. We're going to see death rates continue. They may peak in between September and November, but we will continue to have death rates as long as we have the epidemic continuing in South Africa.
You've covered a huge amount of ground, and I wonder if I can just sort of interrogate some of these questions. So let me ask you about the testing, because your figures, the figures presumably depend on the testing. When I read that the figure's gone up by 4% or 5% or 3% from the day before, I assume that depends on how many tests you've been doing.
Yes, so we're underpenetrated for tests. So we should be getting to about...
So how accurate are these figures then?
Well, they're the tip of the iceberg. So, we've scaled up to about 26,000 tests per day. We said that we would get to 36,000 tests per day by the end of April. And so we're still lagging. So even the predictions for April, we haven't got to, and it's already mid-June. And so we underpenetrated when it comes to testing. So what we're seeing is just the tip of the iceberg, the amount of tests that we can do. So of the 26,000 tests a day, we should be doing more. We should be doing at least 10,000 more. And so what we're seeing in some provinces is a doubling in the last week or so. So if you look at in Gauteng and in the Northwest Province, then the rate of new infections has doubled in the last 7 days. So you can see how it's taking off even in provinces that is not in the Western Cape. And so we're seeing Gauteng province grow, we're seeing Northwest, we're seeing the Eastern Cape, and we're seeing the Free State increasing. And this is to be expected. And it's not, you can't keep the country locked down. We have to try and coexist with this virus as much as possible.
Just on that, I mean, so what do I make, like, if I look at the tests and, like, the results, like one day it goes up by 6%, the next day it's down to 4%, the next day to 3%, then to 5%. There's a kind of zigzag. Is that to be expected? But the tendency will still be up.
Remember also, we've had a whole lot of backlog of testing. And so some of the testing that we've done maybe between 2 and 14 days old. And so some of the zigzagging may be taking account the historical testing, and there may be some degradation of samples. And so there is some imprecision, particularly if your tests are if there's backlog. And so what we have to do is look at it over a week and see how we're doing from 1 week to the next.
And your view is that we're going to, but if you get 40,000 deaths, at the moment we've only got about, I think, 1,700. You know the figures better than I do. But are you surprised that it's such a small percentage of the infections? And it might be even smaller because obviously there are more people infected than are recorded, but the death figure is probably more accurate than the infection figure. Are you surprised that it's low?
So the death rates are around, the case fatality rate is around 2.1% in South Africa at the moment. And that is low, and that hopefully is good news. But we are seeing in our stored data today from the Cape Metro, from Cape Town Metro, and we've just seen a huge spike in deaths, 700 deaths in the last few days. And so certainly, if you go down to at a district level or at a metro level, you start to see the case fatality going up. So the case fatality rate in the Western Cape is 2.7%, and that also depends if that depends on what we're counting. So we do know that there are some Home Affairs offices that are closed, and if Home Affairs offices are closed, you don't get your death certificates. We also know that you may die before you get to a hospital. And so your death may not be recorded as COVID. It'll take us, so to accurately approximate the amount of deaths that we have from COVID will take us probably a year after the epidemic. We can go through all the death certificates and the data, but we are tracking on a daily basis. So we know how many people died last year and how many people died the year before. And we're tracking that based on historical data. The case fatality rate in South Africa is low, and it may be because we have a much younger population. We have a youth bulge, and we know that in Europe, the population is older, and so they may have more comorbidities and more much older people that got infected. So maybe our youth bulge may be protecting us in some way. And or maybe we are undercounting our deaths at the moment. But 40,000 deaths by mid-July is sobering. It's about the kind of deaths we would see in TB in 1 year.
That's an extraordinary amount of deaths occurring in the next month or two. Is what you're saying, really?
Yes.
Can I ask you this? Sorry, carry on. Sorry.
Yeah. So yes, if the models are correct, hopefully, as I said, models are imprecise, and you're as good as what you can feed into the models. So, so we can give estimates and say, well, this is the range of deaths that may happen, and hopefully we get to the lower end and not the high end.
So let me ask you then on that: do we know whether people who have TB or HIV are more vulnerable, or have we not learned that yet? Are we still trying to find that out? I know that the general tendency is that people of my age, particularly if you're diabetic and so on and so forth, you're much more vulnerable. But I'm interested, do we know about the HIV and the TB stuff? Is that an indicator that people are going to be more vulnerable?
So we've seen data, so obviously this data will emerge, and from the Western Cape we are seeing data that obviously the older you are, so the data does follow the rest of the world in terms of age and comorbidities, but we also are seeing that HIV and TB are risk factors for death, and that if you have active TB, you're at risk for mortality, and also if you are HIV infected. So we are seeing an influence of TB and HIV on the death rates, besides diabetes, obesity, and kidney disease, and age, of course.
So let me then, just moving on then, a lot of economists, I'm basically referencing perhaps Paul Romer, the Nobel Prize economist, who basically said, you should be opening up just like we did, but if you had proper testing, and if the testing could come through very quickly, then, in other words, if I had a certificate saying I've been tested yesterday and I'm fine, I could go to my dentist and my dentist could feel free to, or I could go on a plane. So he was saying that was why they were particularly interested in the saliva tests for this, because the quicker you get the turnaround, the more you can open up, because the more you've got some idea of who is at risk, etc., or who's going to risk other people. Are we going to get to a situation where we're going to get testing where people will know, where the authorities, everybody will know within a short period of time that you either are positive or not?
So at this moment in time, the best tests that we have got are what we call the RT-PCR tests, where you take the nasopharyngeal or the oropharyngeal swabs and you look at molecular diagnostics. And those, we should be turning those out in 24 hours, with between 24 and 72 hours. And based on that, you should be able to contact people and trace them and contact their contacts so that you can contain the epidemic. So the whole aim of testing is to make sure that you can follow the person in a timely fashion and contain the epidemic around them. And the kind of tests that you're talking about, the antibody tests, are problematic because they're not sensitive or specific enough, and they only are positive days after your infection. So the damage would have been done, and so you would have done all your infections, and you would know that you had your antibodies. But we also worried about reinfection. So we don't know how long these antibodies that you get post-infection, the immune response post-infection, how long that lasts for, and whether that protects against reinfection in the future. And so these immune passports are probably not going to work because the diagnostics that we have are not good enough. And even if you do the RT-PCR, if it's negative today, it doesn't mean you're not going to be exposed tomorrow or the next day. And so you should behave as if you were infected and protect yourself and your community. It's much like where we were with HIV, where we said if you don't know your status, behave as if you are HIV positive and protect people on the onward progression of the disease. And likewise with COVID-19, we have a responsibility to contain the epidemic as citizens and protect the next person.
And that's, of course, what, as I indicated to you earlier, what worries me is that's the sort of almost, it is a psychological issue. When you lock down 5 or 4 and you can't go anywhere, you take it more seriously than all of a sudden where now you may be even able to go to a restaurant.
Yeah, I think it's the risk benefit. Yeah. It is. I think it's the risk benefit, and I think that you also have to do your risk assessment. If you are 22 and you're fit, there's no reason why you should be caged in. But if you 85, with comorbidities, you should not be running around going to bars and restaurants. You should be staying at home and watching movies and taking care of yourself. So I think it's also about understanding your susceptibility, your vulnerability, and how you protect yourself in your situation.
But then can I just say, if we get to the 40,000, well, sorry, let me just get back to the testing. Can you envisage a situation where we're going to get turnaround time in 24 or 48 hours? Because surely that would make, I know it won't be perfect, but it's a hell of a lot better than what we'd have at present in terms of trying to regulate.
If we could get to that stage where we could test within 20, if we could have a turnaround time of 24 to 72 hours, we could make a huge impact on the epidemic. First of all, for people in waiting, for healthcare workers who are exposed to persons under investigation. It's also for persons under investigation to know how to manage them. And it's not just that, it's just, we have pregnant women, so we have 1 million deliveries happening every year in South Africa. And, how do we manage our deliveries? How do we manage cesarean sections? So if we had a quicker way to test, we would have a better feeling of the burden of COVID in our communities or in our hospitals or in a setting. And if you can't test in a hospital, the best thing to do then is to make sure that our healthcare workers have PPE. So if you are in a labor ward, or if you are in a emergency room, or if you are in a pediatric ward, we should be making sure that we're cleaning our surfaces, we're decontaminating the areas, and our healthcare workers are protected as they look after people who are sick and require care.
But does that mean, and can I ask you, can you foresee the possibility of us getting to a 24-hour to 48-hour regime of testing?
Well, I'd like to believe that we have the capability, but obviously that comes at a price. And so the very backbone platforms we're using to test for COVID are used for TB and HIV testing. And so that we're using more and more, we're using these platforms to test for COVID, and which means that other tests get put on the back burner. And so everything comes at a price. We have a fragile health service, and we don't have endless capability. And so as you shift resources, other areas of your health system start to come under strain. And so for us, we worried obviously about HIV and TB. We know that people are not coming forward to be diagnosed, and maybe as we ramp up testing, we replace COVID testing, we replace TB testing by COVID testing, and we further don't make TB diagnosis. So that's the problem. So we could scale up, and we have an amazing infrastructure to scale up. We did it with TB and HIV, and we're using these very same platforms. But also at the same time as having the platforms, we also have a global shortage of tests. And so we're also competing with the bigger economies to bring tests into our country. So it's the human resource, it's the laboratory infrastructure, and it's also the availability of tests to be able to test at that level.
It's a money problem. It's a access a resource problem and an infrastructure problem, if I could put it that way.
Well, that ends up being a money problem. It ends up in not having.
Money could not be a problem because it's actually quite cheap at the price, in the sense that if you were able to test people, you in fact would probably have a healthier workforce, which in a sense is cheaper even in the medium to short term.
Well, testing is important.
You'll be able to regulate that better.
Yeah. So testing is important, but we're going to get to a stage where just about every place of work is going to have a COVID exposure as more and more people get infected. And the way we manage the infections now and the way we might manage them in 6 months down the line is sure to change, particularly as we get to know what the natural history of COVID infection is in South Africa. We might, in the Western Cape, we're not testing anyone under 55 if they're symptomatic, because we know that even if they do have COVID, then they're not going to die, and they probably don't need hospitalization. And if they do, they'll come to the hospital and then they can be tested there. And so you might get a situation where even if a 22-year-old is symptomatic, they're not going to do badly, and so you don't want to waste a test on them, and you would rather that they protect themselves and self-isolate.
But they could infect your 55-year-olds.
So that's where you have to be. That's where the citizen, where we need a compact with the citizens. So if you're in an intergenerational household, you have to maintain social distancing. I have colleagues who've tested positive, who've had their elderly mother-in-law in their house, and they've managed to keep her separate, even though the house is small, and she's remained uninfected despite the fact that both the husband and wife became infected. And so with a little bit of with implementing the principles that we speak about, you can, even in a small household, find ways of containing the spread.
Now, you've made reference to the fact, which of course is, it's an uncontroversial point. It's not only yours. I'm not being disrespectful, but I'm just trying to make the point that we've got an agile healthcare system. And there are some people who say that the Western Cape is perhaps better organized than some of the other provinces, even though they've got more at the moment. And when the sort of levels which we see in the Western Cape transmit to the other provinces, the question is whether the hospitals won't be so overwhelmed that we have more deaths because we can't even cope with those people who ultimately are flooding to the hospitals, which are not coping. And would that then mean, would that be so? And if it is so, does that mean that in some areas you may well have to have some more stringent regulation, i.e. a higher level of lockdown?
Sure. I think that what you have to look at, so Western Cape is well resourced, and they have, gone very far in developing their public-private partnership to bring on the private sector. And as you get to other provinces, or as you get to districts that are more fragile, we are going to be struggling with resources and how you manage that. And so, and there's a lot of balls you have to manage. I'm sure you've seen as we've opened up the economy and allowed liquor to be sold, and we've seen a huge surge in emergency room admissions, car accidents, and intimate partner violence. And so not only are you contending with the COVID epidemic, but you're also now contending with alcohol-related mortality and morbidity, which takes up your time. And so you have to, and maybe one could argue that maybe not prohibiting, prohibitions on alcohol were more sensible than prohibitions on tobacco.
I would have thought so. Careful not to ask you about that, but you're very welcome to answer that.
Well, I do think that we should have been sensible about alcohol.
Let me put this to you. People listening to this, not that I'm a smoker and I abhor smoking, but the fact of the matter is people listening to this, including people like myself, are going to be scratching their heads and saying, I can get around, even though I like my glass of wine or my beer, I can get my head around the alcohol prohibition. I can't get my head around the cigarette one. And I suppose the point is, it is about explaining to people, surely.
Yes, there's clear evidence that alcohol, there's a correct direct relationship between alcohol use and hospital beds being utilized because of car accidents and violence. And so we saw during lockdown, we saw the rates of non-natural deaths plummet. It was astounding. And then we saw as we lifted the alcohol prohibition, we saw the death rates related to alcohol come up. So the data is there. There's evidence of that. And it doesn't. You don't need to be a rocket scientist to make the correlation. And perhaps slowing down or minimizing liquor consumption, maybe not selling 750 mils of beer, but selling the 250, 350 dumpies, whatever you call them, or maybe making sure that you can only buy one bottle of wine a week using your ID numbers. We should have limited the excess use of alcohol in our country. We know we have an epidemic of violence, injuries, and car accidents, and we know what causes that, and we know what the drivers are. With tobacco, it's difficult to understand because we know that nicotine addiction is a powerful addiction, one of the biggest addictions that you can get. We know that contraband or illegal cigarettes are available everywhere, and that they're expensive. And so when you have an addiction, a nicotine addiction, you're going to go anywhere to get your cigarettes, and they're available. And you're going to pay a large price, which then deprives your child of a plate of food. And so it does seem that the issue around tobacco was not well thought out, and that I understand the need to control tobacco and to regulate tobacco, and I know that tobacco is really bad for your health. And since we've had all the regulations as far as tobacco is concerned, we have seen the deaths because of respiratory deaths come down, because of tobacco come down. And so there is a correlation between controlling tobacco and a reduction in deaths from respiratory illnesses. However, this is maybe not the time to do this, and maybe we should have thought more carefully about alcohol and tried other means to limit tobacco use.
Okay, I'm running out of time. I mean, I could spend hours discussing all these issues, but let me ask you two final sets of questions. Firstly, I understand now that there's some fairly accessible drug that will slow down deaths for those on ventilators and oxygen. I take it we have that drug, and I'm assuming that we're going to use that drug.
Yes, so it's called dexamethasone, and it's a drug that's available.
Yeah.
It's available everywhere, in every clinic, in every hospital. It's a steroid. It's an anti-inflammatory. So the side effects of coronavirus infection is you get a cytokine storm. You get a huge your immune system responds in a way that affects your organs, including your lungs. And so the steroids act in a way to dampen the immune response and help you if you have severe or moderate disease. So they help you if you're on a ventilator, and they help you if you require oxygen. And so steroids are a miracle drug. They helped us with asthma, and hopefully their use in COVID infection will help us manage people who are on ventilators on oxygen. And so hopefully at a global level and in South Africa, there will be a rapid assimilation of these findings into practice. Obviously, we have to continue to watch to see whether these effects are sustained and whether they are have a true impact in South Africa.
And do you foresee that there'll be other drugs of this kind? Not the vaccine. I'm just talking about drugs that will assist people through the worst.
So there are drugs that people are working on. They're antiviral drugs. There are monoclonal antibodies that the US is going into trials with. So using monoclonal antibodies for people who have the disease or if they've been exposed is one way of managing the disease. Using antivirals, which there are a couple of trials underway, and a lot of work on anti-malarials that are being evaluated here, as well as some anti-HIV drugs, which have an impact on and hopefully reducing viral shedding. And so I do hope you might see a combination of interventions, both steroids, oxygen, antivirals, and hopefully monoclonal antibodies that we could use. And these will happen towards the end of the year as we start to understand how they work in the US and other parts of the world.
And then finally, the million-dollar question, the vaccine. Is it something that you think, I'm not holding you to this, but is this a viable possibility? It
has to be a viable possibility. Mm-hmm. So there are 3 programs that are going to come to South Africa, and already there'll be a program that will start very soon, and that's the Chimp Ad program run by Shabir Mahdi, and that will start hopefully next week. And then close on its heels is the Ad 26 program. We've been working in that program with HIV, and we've are now collaborating with Janssen and J&J to be part of a global vaccine trial with this Ad 26 platform. And we're also working with people on another Ad 5 platform, and hopefully we'll be doing some trials in Western Cape, in Khayelitsha, to look at that. I think we lost each other. I'll just end and say hopefully these vaccines will be available and affordable in our country, and that we can use them as quickly as possible.